is microcystic lesions of the corpus callosum. And I will begin, because I'm the older, and because I present the adult part. And for the adult, you know, when you have spots in the brain, the first diagnosis you think of is multiple sclerosis with the little defect. You see, does it corresponding to the scars of the inflammation. When there are numerous, the corpus callosum is big, but also more than multiple sclerosis, and specifically when there are only lesions of the corpus callosum, you have to think of the secret syndrome, which is a vasculitis, which touches retina, ear, and brain, and which makes those little spots corresponding to scars of vasculitis. And it is very interesting because white matter around can be normal, and this is really the specific location for this disease. Of course, it can be also enlarged perivascular spaces, like in this case. It's seldom in adults, and it can be a whole, a sequelae. It can be the sequelae of ischemia, for example. It can be a sequelae of a disease we have a lot in France because we are big drinkers, which is a Macafavia Bignani. But you notice that Italians also drink a lot, and it is like a sort of inflammation, demyelinization, and after there are all in the corpus callosum, like in this example, and it can be also a scar, the scar from a traumatism, a scar from hemorrhage. This is, for example, a scar from surgical approach. And also, and this is a very specific image, that's why I showed this image to you. When you have a chronic hypertension, intracranial hypertension, and when you shunt the patient, there is like a shock on the corpus callosum, and there are like a traumatism lesions of the corpus callosum, and you have this very specific aspect with sort of stripes in the corpus callosum that are in high signal on T2, low signal on T1, and in this case, you see, it's like the surgeon used his teeth to operate the patient, and there are some holes in the corpus callosum. And this is very important to remember. This is my diagnosis, and now the diagnosis of Nathalie.
So it is Teliam, he is 2 years old, he has a mental retardation with learning difficulties and speech delay, and we have this. So he has a hearing loss and visual disturbance and a macrocephaly. Yes. Yes, it is not a multiple sclerosis, it's very rare in children. We have no Suzanne and Françoise in children. So, the main diagnosis is mucopolysaccharidosis. The cysts are due to an enlargement of perivascular space, the virus Sjögren space, resulting of glycoaminoglycan accumulation, and it is a cribriform appearance in the periventricular white matter, corpus callosum, and basal ganglia. And it is a group of inherited disorders caused by a lack of specific lysosomal enzyme involved in the degradation of glycoaminoglycan. And we have 3 recognized entities, the Hunter, the Shire, and the Hurler syndromes, with 11 enzymatic deficits with 7 different diseases. And I will show you the dysmorphic features with a scaphocephaly, a large head with bulging frontal bones, here an enlarged lip, wolf head open, depressed nasal bridge. So, in progressive mucopolysaccharidosis is a progressive multivisceral disease that involves musculoskeletal system, heart, lungs, hepatosplenomegaly, the eyes, and there is a variable mental retardation. You have also a progressive lumbar gibbous or kyphosis, and you could have a corneal clouding. So, there is a cervical spine involvement with a C1, C2 subluxation, and you have here a cord compression. So there is a lot of complication, developmental delay, hearing loss, limited language, hydrocephalus, chronic fatigue, myocardiopathy, and we have a diagnostic test with an urinary test, urinary expression of glycosaminoglycan, and the treatment could be a bone marrow transplantation or an enzyme replacement therapy. And it is very important to know that due to the progressive nature of the disease, early diagnosis and early therapeutic intervention is of major importance. So you see here the child, in a child who is 8 years old, with the Virchow-Robin space enlarged, the white matter abnormality here, very ventricular, and you see here a NEURO with a narrow cranial cervical junction with an enlarged VR spaces. So Françoise, my message is corpus callosum microcyst in a child. Always rule out a pathology like mucopolysaccharidosis before talking of physiological enlarged Virchow-Robin spaces, especially is associated with macrocephaly.
We are done. Okay, so the next lesion is hypersignal T2 and flare of the brainstem and thalamus. For an adult that it doesn't fit exactly the picture we saw, we consider first venous or arterial ischemia. This ischemia is due to a specific artery obstruction. Percheron. Perfect. Percheron that supplies both thalami, and when it is occluded, both thalami are separate. And it is associated with some occipital lesion. And you see different cases when those locations are due to arterial abnormalities, but also when you have a thalamic lesion, you must think of vein thrombosis, central vein thrombosis and basal vein thrombosis. And it is very important because the treatment of venous thrombosis is mandatory, even if, like in this case, there is some bleeding. I will just remember that the hematoma due to venous thrombosis are treated by anticoagulation, which is frightening. It can be toxic or metabolic, like in Wernicke myopathy, where you have, in the same time, white lesions around the aqueduct and the lesion of the thalami. Osmotic myelinosis, or Wilson disease, which a little look like the image I showed you. Of course, in every encephalitis, edem, you can have at the same time lesion of the pons and lesion of the brain, but which do not fit exactly, I must admit, the images we shown you. In Behçet disease, you know that in this disease there is a lesion that is often from the thalamic to the peduncle, but generally it's just one side. And of course you can imagine that a brainstem glioma can goes up in the thalamic. But I think that it's more interesting to look at the children because it's a very specific image.
Hervé is 7-year-old and previously neurologically normal. He has in 2007 a coma with a fever, and he has a regressive neurological deficit. It is very important, this story. And after, 4 years later, he has a new episode of coma with fever. He has an acute encephalopathy, seizures, and rapid progression to a coma 3 days after a viral illness. He has an increase of cerebral fluid protein, and no metabolic or infectious disease. And he has the bilateral hypersignal in thalamic and in the brainstem. You see here, and with this story, you should perform the diagnosis. So, it is an acute necrotizing encephalopathy due RANBB2 mutation. It is always the same neuroradiological sign. It is first described in East Asia, and it is mainly young and healthy children, no previous neurological history, and 2 or 3 days after the onset of a viral illness, you have a recurrent acute encephalopathy with fever, seizure, and rapid progression to a coma. Involvement of the brainstem, thalami, without involvement of the striatum. You are going to see after the caudate and the pallidum are safe. You have an increase of the CSF protein and a progressive improvement. Very important. It is a recurrent acute encephalopathy with a progressive improvement. Initial differential diagnosis was a mitochondrial disease rolled out by the clinical evolution because of the progressive improvement. So you see the same radiological sign every time, multiple symmetrical hypersignal T2 on the brainstem, on the hippocampus, on the thalamic structure, and on the external capsule. Very important, the external capsule probably is pathognomonic. So, Françoise, my message, child with brainstem and thalamic hypersignal T2 lesions with previous viral infection and coma with fever, think acute necrotitis encephalopathy due to the mutation of RANPP2.
Next image, and this is an image you can find in your patient. Periac-ducal hypersignal T2 and flare. Which is this? For an adult, it is